This patient is stable. Close his incision.
Why?
We are expecting an influx of trauma patients. Per emergency protocol, you and I will be in charge of triage. We need to ensure that operating rooms are available to the most critical patients. This man is not one of them.
Close him up.
All right, look alive. Here we go. Incoming.
38-year-old male pulled from his minivan. Mom and 2 kids are on the way.
Here's the triage team.
GCS 12, hypotensive, clamped his temporal artery, belly is distended.
All right, he's surgical. Stabilize him and get him up to the OR.
Dr. Manning? Got it. All right. Dr. Choi.
40-year-old male, GCS 15 setting, 90% on a face mask.
Halsted?
Got it.
No, I got this one.
Severe burn, make him warm, comfortable, and move on. There's nothing more you can do.
Naima?
63-year-old female, went through the windshield, 000, down for nearly 20 minutes.
Stand down. Thrown from a vehicle with a high deceleration injury, most likely a torn aorta.
We can't be sure.
Regardless, stay systole for 20 minutes. This is not a survivable injury. Hold compressions.
Wait, let's warm her up first.
Dr. Rhodes, understand that today we need to focus our efforts on patients with the best chance of survival.
Because of emergency surgeries and a pregnant mother's serious bleeding disorder, we have used almost all of our O-negative. We can either treat Benjamin or Josh, but not both.
Well, I'm sorry, Natalie, but Benjamin needs an angioembolization more urgently than Josh needs surgery.
Well, hold on. Josh isn't compensating for his blood loss as well. He's in worse shape.
I appreciate you both advocating for your patients, but emotion may be affecting your judgment. Our recommendation needs to be based solely on clinical criteria. So I'm handing it over to the triage team.
Dr. Rhodes, your opinion.
I have to agree with Dr. Halstead that Benjamin needs angioembolization more urgently than Josh needs surgery.
Not the issue. We're here to decide who has the best chance of survival. So.
Unfortunately, even if Benjamin gets the embolization, there's only a 15% chance that the bleeding in his pelvis will stop.
Exactly. Whereas with Dr. Manning's patient, as the pressure in his thighs builds, the bleeding will eventually slow. Worst case, Josh loses a leg, but there is no question he has the best chance of survival.
Okay, everyone, listen up. Glad you made it in.
Wasn't easy. We've got a pre-dawn pilot, multiple traumas en route. Whiteout conditions, staff snowed in at home, no supplies coming in. We need to make do with who and what we've got on hand.
All right, Dr. Manning and Halstead, let's decompress the ED. Anyone who's stable kicks back into the waiting area.
Copy.
Dr. Wheeler, be ready to glove up. April, we need every room we've got. Let's kill the hallway, supply room, anywhere we can fit a bed. Let's go, people.
On it.
Doris, put out a hospital-wide alert and page the triage team.
Back to the waiting room. We've already waited an hour.
I apologize, Mr. Kellogg, but we'll get to you as soon as we can, all right?